Good morning, everyone, and welcome to the final day of the 2022 North Country Leadership Summit, Optimizing Healthcare, Community Collaboration, and Workforce Resiliency. My name is Andrea, and I'm with Adirondack Health Institute. And I'd like to welcome everyone this morning. I'd like to also just give a thank you to our many wonderful sponsors. Without them, we would not be able to host such a successful event. So thank you for your continued support. And just a few housekeeping items. We are asking that you place all of your questions and comments in the chat. Staff will ensure that your questions are answered during the Q&A portion of the session. We're asking all attendees to remain muted with videos off to support broadband connectivity. And all presentations are being recorded and will be archived on the North Country Leadership Summit webpage. And those recordings will be available within the next couple of weeks. As a reminder, this is the final day of Summit, and we do have additional presentations at 11 and 1 o'clock today. But I would like to introduce our first presenters of the day, Dr. Akanksha Anand and Michael Simpson from SUNY Plattsburgh. So I will hand it over to you and you can share your screen and get started.
Okay, hi everyone. Good morning. Slightly different weather today, but I'm excited. I'm so grateful to Adirondack Health Institute for inviting us to present at this conference. It is a privilege indeed. I am thrilled to present about this topic that we've been researching on as a team at SUNY Plattsburgh. Andrea, thank you for an introduction, and thank you to all the team at AHI for having us prep and finally present this. I also want to thank my team. I want to thank Mike and all the other team members who've helped me review some of my work. So let me tell you our interesting, exciting work. So we basically research. I'm a faculty. I'm a director at the Department of Social Work at the Department of Health Education and Human Services. My interest areas lie in studying healthcare, optimizing healthcare organizations' productivity, also looking at workforce retention, burnout, and how we can create supportive organizations for the workforce. And one of the topics that often caught our attention prior to COVID and after COVID was retention of workers in the healthcare workforce. And that is something we wanted to review. Initially, before coming to Plattsburgh, SUNY Plattsburgh, I was in the city. This was a part of my PhD dissertation, so this became an extension of my work. So what we looked at was social determinants of health in rural parts of New York and the healthcare workforce. We looked at turnover and retention. So I wanted to see, is it different from rural and urban areas, or what are certain things that we found? So we conducted a scoping review, and this is what we found. So this is just the background of the presentation. Why is it that we're talking about workforce retention? Why is it that we're talking about burnout? All those different things. Why are we talking about nurses and physicians? Why are social determinants of health important in rural New York State? And what are some strategic interventions that we found that have worked, not just in the US, but also in other countries? And also, what are some organizational environment factors that play a critical role in, serving the interdisciplinary approach to comprehensive care in some of these healthcare settings. Some of the results we found, we're going to talk about some models of care we found, what are some strategic ways to serve underserved areas, and what are some health and well-being strategies that we could use to employ or to have people take on residencies or take on roles in rural healthcare settings. And what are some steps of analysis we used? And of course, like any other study, the study also has limitations. And so we'll talk about that at the end. So I start with this presentation. I dedicate my work to the healthcare heroes. I know all of us are in good health and all of us have survived a huge pandemic. And without these people, I don't think it would have been possible in New York City. And New York City or New York State in general, Burnout since 2019, even prior to the pandemic, has been declared as an occupational phenomena. So basically, burnout is a syndrome which is conceptualized as chronic workplace stress, and it has not been successfully managed in organizations prior to COVID as well. So now it's become more so an issue impacting social determinants of health. If we are stressed, employees are stressed, the quality of care gets compromised at hospitals and healthcare settings. And that's what we're going to see today. I'll give you a background of why there's such an urgent need to address this. Um, this is because our workforce is changing. Our workforce, as we are seeing the unemployment statistics go up, we're seeing our workforce it consists of more women in the workforce, single parents in the workforce, and dual earning couples. We have, even prior to COVID-19, we've seen a high caseload amongst frontline hospital employees or healthcare employees and unsatisfying work conditions, or which leads to turnover and suicide. I wouldn't want to say this, but it's sad that after COVID-19, the work stress just got so much to the workers that it was leading to trauma and leading to PTSD, post-traumatic stress disorder, in unprecedented times in COVID-19. In 2020, the Bureau of Labor Statistics projected that there will be a 14% increase in the need of these healthcare workers. And in order to address these stress costs, we'll have to almost spend $125 billion a year, which is a lot of money being spent in lost productivity and all other healthcare costs associated with stress. Currently, are there any stress interventions that could address this so that we could impact social determinants of health? Very few. There are individual level and organization level interventions. As I present, I will talk more about them. This is a chart that explains an interesting phenomena that's going on. So this was a study that was done in like 2019 and 2011 to 2019. They looked at how different specialties within healthcare are impacted by burnout, right? And so some of the researchers argued that emergency medicine had the highest rate of burnout, highest rate of work-life conflict, and reduced job satisfaction, which means that in like 50%, more than half the US physicians were now experiencing professional burnout, right? And one in four nurses reported burnout as well. There is a similar chart that explains a more elaborate version of it. So if you look on the left, it says percentage of workers satisfied with their work-life balance versus burnt out. So you'll see right at the top here, 70% or above emergency medicine employees, that is nurses, doctors, physician assistants, frontline clinicians, social workers, crisis intervention workers, all of them are far more stressed even prior to COVID. And all of this only got furthered because of lack of resources with COVID-19 in these settings. Why is it important? Well, social determinants of rural healthcare and turnover and retention is something you're talking about in rural and remote areas. Now, all of us know that with COVID-19, telehealth and telemedicine have gone big in the US. And what this does is we already had disparities in amongst the rural population compared to their urban counterparts, but we're seeing poorer health outcomes with rural populations as a result of not having enough primary care employees or enough mental health services or enough healthcare resources for the rural populations. Why are we talking about upstate New York? Why are we talking about the 7 counties in North Country region? Is because they are federally qualified healthcare professional shortage areas in mental health services and primary care services. That's where they get all the chronic care and all of those. One of the major contributors of healthcare disparities is a chronic, severe shortage of workforce. As compared to the metropolitan areas. This is not just a phenomenon in the US, it is a global phenomenon. You will see the same thing happen in Australia and other countries, some of the developed countries. So and this topic has gained more importance because retention in rural areas is far more difficult than in urban areas, right? It's easier to hire somebody in an urban setting versus a rural setting. And we also saw that in urban settings, there was a high burnout rate and retention rate. So we were seeing a similar phenomenon in the rural areas, and now there's a direct impact with the quality of care and the access to healthcare to some of these rural populations. right? And there is very little attention being paid to this right now. And I don't know how. I'm not a telehealth expert, but I will tell you this. I don't know if people are very happy with the access to resources through telehealth. We are getting there with developing our digital strategies to have access, but it's going to take some time till we get there. Has the workforce been resilient? It's going to take some steps for the rural health workforce to be resilient. And there's more research that needs to go in how we're going to have our employees be resilient and, come walk through some of these difficult circumstances. Uh, when I was reviewing some of this work, I found this interesting quote from the New York State Health Commissioner, which said that this challenge, combined with exacerbated health workforce shortage, is adding to burnout and dissatisfaction amongst public health workers and is sounding an alarm for public health networks nationwide. So, like I said, it's not just a phenomenon in the US, it's a phenomenon worldwide, right? But it's a good thing that at least our primary stakeholders or tertiary stakeholders or secondary stakeholders are interested in the topic. And New York State is, it's promising funding in these areas, which is important. Well, one of the things when I was writing this paper was that what are social determinants of health? Do we know what they are? The World Health Organization says these are environments we are born in, we grow in, live in, work in, and age in. And if there are adverse factors in these environments, whether it's workplaces or whether it's home or neighborhoods we live in, there is going to be a crushing impact of stress on us. And we tend to neglect self-care in those times. And if we assess the problem early, then we can have an early healthcare intervention, which does not exist right now with rural parts of New York. This is a chart that actually explains what are social determinants of health. I got this from the CDC website, Center for Disease Control and Prevention. The goal of Healthy 2030 is to target strategically these 5 interventions, which have to be focused around economic stability, providing people employment, access to economic resources, giving them educational opportunities, because if you know better, you do better, right? And then access to healthcare. New York State and rural areas serves 4.7 Medicare beneficiaries through these primary healthcare centers and primary care centers and mental health services. So the beneficiaries through the social welfare policies are a large in number, and not having enough staff to assess their needs impacts the quality of care. Also, the neighborhoods and environments, like we all know about food banks in rural areas. We don't have, in New York City, you'd have access to a full whole food or a more have access to food, then you'd have access to food banks in rural parts of New York. Same thing with social and community context. If we are thriving in the communities, if you're having fun, the simpler way of saying it, if you're having fun and you feel socially connected to the community, you're going to enjoy your workplace. So if you enjoy your workplace, you're going to have productive outcomes. Your quality of care you provide is going to be far better compared to others. The social determinants of health have these 5 strategic domains, and those are the domains that I've looked at and compared it with burnout and retention and work-life conflict. Why rural areas? There's a severe shortage. I'm not saying it, the data is telling us, the research is telling us this. Why rural pockets? We have a large senior citizen population. I lived in New York City for years, and now that I moved here in upstate New York, it's been a privilege to work with the senior citizen community. But the community is actually struggling because we don't have enough primary care workforce, or we don't have enough healthcare employees to help them. So, of course, younger people are not staying in rural areas; they're moving to metropolitan cities for jobs, and this is a challenge in attracting healthcare workers to rural parts of New York. Another thing, like which I said before, like there are a lot of Medicare beneficiaries, about 4.7 in New York State in rural areas, which makes it difficult to serve if you don't have enough workforce. I found another interesting quote from our governor, who said that we need to augment our healthcare resources in the next 2 years. So it's not promising that there has to be money assigned to this, but it is good to see that our leaders are focusing strategically on the budget, of spending 20% of their budget towards workforce retention and some of these initiatives. I think she's planned a budget of $216 billion in budget plans by the end of this month. And she also says the state healthcare workforce has been depleted in the last 2 years. So we had this problem before COVID. And now after COVID, we've gone in a severe retention and gap. As my presentation unfolds, you'll see the gap comparing state to local level data. The goal of this grant or the money that state is spending is to have more strategic initiatives, a range of initiatives to incentivize people to work in rural areas, and this budget will be geared towards spending money incentivizing people and bringing them to rural areas so that they can serve the population, the much needed population here. So the New York State Department, of course, recognizes it as a public health challenge. It essentially highlights that if this shortage of public workforce continues, we are going to see a challenge of disparities. And this was published in the National Public Health Week, that diversity and retention has to be a statewide a statewide program. It cannot just be focused on, okay, we could just look at these rural areas that are far more affected, but we have to strategically, with the resources we have, target certain pockets more than others that need more help. And also there's a $4 billion budget being promised to support these wages and incentivize healthcare workers to work in rural areas by 2023. Okay, so this is the meat of my whole presentation. These were the 5 broad themes that emerged in the literature from what we reviewed around social determinants of health and retention of the workforce. I'll just go through them briefly, and I'm going to have Mike step in at the end of the presentation or maybe now to fill in on some of these things. They're very, I wasn't surprised by finding these, and I think me and Mike have talked about this. Rural healthcare facilities have familiarity and access is a problem for workforce retention, and also the internet. There's not powerful internet connections or broadband internet connections to have access to inter-hospital connectivity or community-based resources to connect with people in need. There's also a need for social connections to address isolation with senior citizens, and not just with senior citizens or the clients we are serving, but also when people get hired in a rural area where they are not a part of the community, they feel isolated even as the workforce or the workers. So we need to engage, we need to be engaging more in community engagement projects around workforce retention and social determinants of health, and have more communities participate in it. One such example is our Center for Neurobehavior Science, which Mike can talk more about. It's basically giving access to senior citizens, and it's an application plus a resource center at the psychology school that gives access to senior citizens with Alzheimer's and help them with resources. So basically engaging the community in university-based research. We'll talk more about it. Another thing is that if employees are more likely to have life satisfaction and they're more likely to have better health outcomes, they sleep better, they're happier, they're more productive. That's one theme that came out. So that you have to keep your employees satisfied if anybody in the healthcare workforce, anybody from the hospitals is here. Another thing we found effective was social support networks affect retention in rural healthcare workforce, meaning that if we provided team-based care where nurses, physician assistants, and doctors, all of them, the medical care team is working together with a lot of support around them to work, they're more likely to not turn over, and there's likely to reduce turnover and increase retention of the workforce in rural areas. So these are the 5 broad themes. Mike, would you like to talk about the piece now or later?
Well, certainly I can remember back in 2010, the college was involved in a project called the Adirondack Champlain Telemedicine Network. And back then, I remember one of the hospitals actually was running its whole hospital off a cable modem. And that grant allowed us to get a gig to each hospital and 100 megs to each clinic. And that was a huge improvement. For the first time, if somebody had to go from, say, Malone to Burlington, their medical records could get there before they did. And when time can be really precious, not having to retake tests can have a really big impact on the outcome of those sort of situations, just as one example. And then in terms of recruitment, you're trying to recruit a doctor with a family and their teenagers can't have access to the high-speed internet they're used to in the metropolitan area, that can even impact recruitment. but it's internet and access to high-speed internet is certainly a big deal and a big barrier for rural areas.
Thank you, Mike, for sharing that. Mike has published a whole range of this research work in partnership with SUNY Plattsburgh that I read, and that's how we collaborated together. So I'm thrilled about that. Thank you. Thank you for sharing that. And I could agree more with Mike that if you don't have a high-speed internet connection, you cannot access to social connections. So that becomes difficult to access resources or look up any kind of healthcare benefits online or any of those things. The internet connection becomes really slow in some of these rural agencies. And then, of course, it becomes difficult to access any kind of electronic health data that we need in order to assess patients and help them. Okay, so I put these fun pictures here. The Beaumont Foundation did a research report where they talked to Beaumont Foundation did a research report where they found that if you look to your left from 2008 to 2019, there has been a consistent what you call lack of investment in the workforce over the years. So there isn't enough public health workforce in the state, and it is reduced by 15%. And the report basically highlights that we need 80,000 more full-time employees in these positions and increase it by 80% in terms of inadequate infrastructure. So basically what Mike was talking in the earlier part of the slide, where he was saying that we don't have enough infrastructure in terms of broadband connection or connectivity to electronic health records. As a result of that, that impacts retaining, employees in hospital or public health workers in such settings. If you look at this other box here, the orange ticks versus the blue ticks, this represents the 80,000 full-time employees that are actually needed in the state and local level health departments, meaning that we need to have more people be hired in these places to serve our community better. And this needs to increase by minimum of 80% to impact our community areas. We need to, of course, increase staffing, increase infrastructure to provide comprehensive services in some of these emergency settings, basically. I love statistics and I love research, so I put this in here. On the left is your state department need of full-time employees for public healthcare workers. And on the right is your local department for, local department need for full-time public health employees. So you can see that in both the darker blue is the current need and the teal blue is the needed amount of public health workers. So you'll see that at the state level, there's 80% need of workers, and at a local level where we are, rural, there's a 70% level of workforce needed in these local health departments. So you can clearly see that there is a gap in the services that we can provide at the local health departments in rural New York. There's this another graph that I found, and I found it very interesting to see that the same thing follows here. The dark blue is the current, the current and the needed public healthcare workers. And if you look at the local healthcare departments, the local meaning the rural New York, you'll see that there is 7,000 to 15,000. So that's twice the number of people needed currently, and we don't have that. So the earlier slide that says local and state level is 80% versus 70%. This was very surprising to me that a population of 100,000 there's a 50% need of workforce in those areas with such a small population number. So it's just fascinating to see how there's such a desperate need for workers in this area. Well, this was another graph that I got from the same report, and I found it interesting. On the left side, it explains state funding and what is the need for it. So if you look at this, you'll see that the highest number here, I've circled it, it's foundational capacities. That is your resources that is needed in terms of infrastructure, which we already talked about, the broadband, internet, all those resources to access electronic health record to help in decision-making. And if you see the foundational areas of on the health on the left side, you'll see chronic disease and injury. That is a need for those full-time employees in that area the most. So this is the highest number of employees that are needed in total. So basically what we're taking away from this report is that there's a foundational capacity need, and we need public health workers in chronic disease and injury prevention areas. Those are those areas that we are really in need of workers. Another thing that this report highlights from they create this report and which highlights is that there's an existing shortage, and it's if full-time employees were deployed in these areas, and there would be 26,000 to state health department employees that would be needed, right? And state and local departments needed additionally full-time employees in acute care, especially in local areas. So like, how in the earlier graph it said chronic injury and acute care, like those are the areas that we need more workforce in at the local level. However, at the state level, we need approximately about 54,000 full-time employees to be deployed at the local level. So as you see the first point here, you can clearly see that there's a dire need for public healthcare workers more at a local rural level than at a state level. I'm not saying that the state level is not important, but local areas are dealing with this, which impacts the social determinants of health. Again, it's the same thing. Nearly a quarter of needed full-time employees should be dedicated to assessment, meaning that if we had initial assessment of, chronic diseases, or out of those 4.7 million Medicare beneficiaries, we see that nearly 70% deal with one or more chronic. They come in with one or more chronic cardiovascular diseases, right? So what it's really highlighting is if we could assess these patients earlier, we would do a much better job in impacting the community in communities that we are a part of. And by foundational areas, and like I said, amongst the foundational areas in chronic disease and injury prevention are the greatest need for public health workers to be employed at the local level. Of course, workforce shortage is an issue. Stability of these employees in these underserved area has a negative impact on rural communities. That's what the report highlighted. So I did want you to take away how the shortage of employees impacts the quality of care that we provide in some of these rural communities. We have a lot of senior citizens in these communities. We have a lot of youth who are impacted. We have low income. We have first generation going to college at SUNY Plattsburgh. It's just fascinating to see how the demographic is impacted by some of these lack of workforce shortage in these areas. So I'm going to elaborate on all the 5 broad themes that me and Mike shared with you earlier. So what is rural healthcare familiarity and access? Well, rural healthcare familiarity and access is telehealth, access to telehealth services, location-based placement, meaning that if I know this area better, if I'm from New York, I'm more likely to come back here for residency. And if I'm more familiar with the population, social connectedness to their homes. If for employees, if we created an incentives that you're coming back to your family, like students from SUNY Plattsburgh are more likely to come back to Plattsburgh and serve in rural areas. So that's the idea that familiarity breeds content. So we could basically incentivize people to come back to their communities and serve them. Also, we could work with federally qualified health centers. What these centers do is they reduce the gap between primary care provider supply, and also mitigate the shortage of workers of uneven distribution of primary care workforce. So basically, we could also work with federally qualified healthcare centers, because that'll help us strategically address the underserved communities if we provided that access through the internet. There is a need for social connection. Like I said, this was the second point. They said, I looked at the research. I said, what do they really mean by social support network? Well, there are studies that have found that if nurses, physicians, any medical frontline employee, if they found social support networks that they could be a part of, they're more likely to be satisfied and we can retain them better in the workforce. Nurses recruitment and retention is especially critical in rural areas, because healthcare facilities have a 60% facilities take 60% longer than urban facilities to fill nursing vacancies, meaning that you have to spend, of course, 60% more resources to hire a nurse in a rural setting than in an urban setting. And little is known about rural nurses' social support networks and what really works for them. I did my postdoc at Columbia, and in our postdoc, the Center for Healthcare Delivery at Columbia School of Nursing, they argue consistently that the organizational climate and social support networks are completely lacking for nurses, and there is current research going on on what is the best way. One of the things that they talked about was team-based care. Like if we provide a team-based care, it'll reduce the time on each patient, and there are different strategies for wellness, like a rest and recovery break, to you have 15-minute break if you witnessed a death in the ER or at a center. Go back to your desk, take 15 minutes time off before you see your next patient, because vicarious trauma for one patient goes to the next. So we need to provide them with helplines or social support networks that they can go to if they're dealing with difficult cases. And COVID-19, we saw that happen over and over again. And that's why there were so many suicides and PTSD cases with frontline workers. For instance, environmental amenities, quality of life, they influence the decision based on the population, healthcare professionals to set up in a certain area. So if nurses wanted to set up in an area, wanted to be placed in a rural setting, there are a lot of things that go in that. And one of the things that Mike said was about family formation. We're seeing the ages of these healthcare workers is an age where they're in their family formation stages, or they're in those stages. So not having the right school for your family, let's say, or not having the right population to work with. Some people might be great with geriatric nursing versus pediatric nursing. So just having the right work environment that's a good fit to their strengths, that has been a problem, and providing them the right climate and equipment to serve in these areas, which also impacts their retention in these areas. I do see some chat messages. I'll respond to the questions. I'm wrapping up in another like 5 more minutes. On the other hand, demographic dynamics can influence health professions and locations as well, meaning that if I'm familiar with the demographic, I'm more likely to go and work there and be comfortable and at ease. If I'm completely comfortable with working with diverse populations, if I'm placed there, it'll be great. If I'm working in critical care settings, I should be placed in critical care settings. So the settings and the demographic of where these public health workers are serving, it is critical. It is critical as we go forward in looking at building social connections and addressing the issue of isolation. The third point was community engagement and participation. I give you an example of SUNY Plattsburgh doing this Alzheimer's, addressing Alzheimer's with seniors at our university. World Health Organization particularly says that there are two things in social welfare policy: accessibility and availability, which means that some welfare programs or some of these healthcare resources might be accessible but not available. So in order to do those things at the same time, we need to address two major factors of the population health status. One is look at their physical, social, emotional environment, or their entire economic environment they're in. Also look at their social status, and also look at the healthcare supply there is in that area. So maybe if they don't have access to those two things in those areas, we're likely to see a deteriorated impact on social determinants of health, meaning that if you do not have the right health insurance, 1 in 10 people in the US are uninsured if we look at the New York State data. So it's just fascinating to see how access to healthcare, and since we're dealing with an underserved area as well, we are less likely to see we are more likely to see accessibility as an issue. And so if there is a close connectedness with the spatial interactions in between the healthcare workers and the community, you're more likely to see a better impact of those social interventions or any kind of interventions that you're doing with the workforce. And population specific, if I'm comfortable working with a certain population, I would be better placed in that ethnic group or that pocket better than any other population specific area. What that'll do is it'll encourage community engagement projects. If I'm really good at geriatrics, I would be placed in, if I was placed in Plattsburgh, I would thrive in an environment like that, because that's my passion area of work. So that was the thing that they were talking about, that if you involve community in their community engagement as a part of retaining the workforce, it'll become critical to retention. Another thing was life satisfaction. I couldn't find too much around this, but the few studies I found it fascinating in the West. In California and Nevada, when they looked at life satisfaction of physicians, they found that physicians' practice location and choices over their life course have a huge impact. Going back to the same point that Mike also mentioned, where you are in your life really determines where you're going to go with the choice of residency you're going to choose, or where you're going to go and serve in terms of the workforce. If the transition in the community that you're going to seems smoother, you're more likely to be happy and satisfied and very motivated to go to work too. And we have seen that there are some aspects of the job that have consistently created or impacted job satisfaction or life satisfaction of these employees is long working hours. We know an average doctor or nurse works 12 hours at least. These working conditions are high workload and highly intensive. And there is limited support networks and not enough educational opportunities. And these opportunities are further minimized if you're in a rural setting versus urban. Support network influences the retention of these workers, meaning that their decisions to leave or stay, it's a multifaceted decision. So we need to have a multifaceted approach to address this. We need to provide them with support and all the things that I said earlier. It's a complex approach, I know, but it has to be a strategic approach in incentivizing them to stay in rural areas. The last thing that this is an evidence-based framework that says that if you provide people with enough social support network, they're more likely to stay. We need to do a more targeted intervention or have a more targeted approach, so to say, in place informed retention strategies, meaning that if I've been born and brought up in Plattsburgh and I've gone to the city to study, I'm more likely to come back and serve my community because my family is here, my entire social support connection is here. There is no straightforward answer to this, but we have to incentivize employees and come up with some evidence-based frameworks. I will talk about some of the evidence-based frameworks. There's a nice picture that explains it. One such framework that has been found to be effective in Australia, comparing rural and urban areas, is this whole of person retention improvement framework. It basically says that you should account for some few things when you're retaining employees. A picture would explain it better. I'll just show you the picture. So this is the picture. So the argument is in Australia, when they did the study and compared, they found that if our public health workforce had enough opportunities in building skills and career opportunities and worked in an organization or an environment that was supportive and inclusive, and if they were connected to the community, they were more likely to stay in their jobs and not leave. So this holistic approach kind of works. There's another model that explains it really well. So this was a study that was done just last year. So healthcare workforce retention, particularly in low-income areas similar to ours, is this root stem model, which basically says that if you tied up with an academic institution, strategically recruited students or employees, and trained them well and offered them a decent remuneration, and created a more supportive and inclusive environment, it'll be a better return on investment if we did that with our workforce. So this is relatively new research that's coming out from our scoping review. So I thought that was very fascinating, the way they'd created this holistic person and environment approach, which definitely could work in the US too. This research impacts community in a great way. We've come up with some evidence-based strategies, like I shared some models with you. There are some resources that are available. Of course, marginalized community, people of color are significantly impacted by healthcare disparity. And we have an under-resourced healthcare system currently. So we need to work together to kind of address some of these healthcare disparities and racial disparities issues after COVID-19. And so telehealth and telemedicine are the future strategies to go to, like come up with, we should develop digital health strategies like the one that we already have for senior citizens, but we could do a lot more with mental health services. We know that mHealth has become really huge in digital health strategy. So that is one thing that we could address in impacting our communities. Again, what are some policy level changes that we could improve with this research? Of course, we know that Medicare beneficiaries are impacted by this. We should make sure that the delivery of services in these environments impacts some of the most vulnerable populations, and it's critical we account for that. Second is that these environments should be associated with reduced hospitalization rates because it's a lot of cost to hospitals. So we should provide conducive environments for physicians, nurses to work in these environments. Healthcare administration should consider that these environments are quality and improved strategy, meaning that they get rest and recovery breaks. I know all of this works for all of us. When we go for a wellness walk and you come back to work in 15 minutes, you start with a fresh mind. So it allows you to reserve your cognitive resources. And rest and recovery literature basically argues that if you give your team breaks after like 4 hours or so, you're more likely to see a productive employee. So please give your employees and your team members break, because that's really important. And as you are likely to use your cognitive resources better, team-based care, Professor Norville at Columbia, she researches on team-based care, and she said, if as a team, when we work together, we're more likely to see a better co-management of healthcare with frontline employees. And then there was a study that I found that if we invested in these strategies in the next 2 years, we will have saved 4,370 lives, and we will be saving $720 million over the 2 years of period, and reduce the stays of people in hospitals and emergency care and primary care settings, which I thought was really fascinating. So why not invest and save lives and save cost instead of having the existing disparities in healthcare. Patient to nurse staffing also varies in hospitals. So the better access you have to healthcare employees, we'll see better outcomes with our patients and social determinants of health. That's it. I think I said 10 minutes and I got it done. Okay, I'm just going to leave the slide here for feedback, questions, and our email.
Thank you very much, Dr. Anand and Mike. This was a really great presentation, very interesting research. I do see that we have a question already in the chat, which I will read out. And if anyone else would like to place their questions in the chat, please do so. But we have one question regarding the data discussing incidents of injury. Do we know what percentage was related to alcohol and or drug use, or if data collection included analysis or controlled for a secondary diagnosis of substance abuse disorder?
Mm-hmm. Mike, you want to respond or should I respond? Okay, I'll go for it. Thank you. I think it's a very good question. The objective of this research was to just look at the existing literature out there. So the report that the foundation published, that report did not give a breakup of the statistics as to how they looked at those foundational areas. But I do know, being here and being a faculty here at SUNY Plattsburgh, de-addiction is a very big problem. And drug abuse and recovery is a very big problem. So definitely, I think the point you're making is very important and critical in rural healthcare, because accessibility to mental health services is so low, because this is also a federally qualified HIPAA underserved area. And it would be fascinating to see the comparison of those variables. So the answer to your question is no, we did not see a breakup of that chronic injury or disease incidents in that data set.
Thank you. We have another question that came through. Are states investing in student loan forgiveness for rural service?
They have incentivized program for nurses. The little that I know of at SUNY Plattsburgh, yes, there are scholarships being offered. There was also a statewide policy that was implemented to recruit more student nurses. And the program has gone completely online to make it a more comprehensive program so that students can be better prepared. And we work with different hospitals, different healthcare agencies, where they can be assigned internships where we already have relationships. So yes, we're doing that already.
Thank you. Are there any other questions? And again, feel free to put your question in the chat, or if anyone would like to unmute themselves and ask a question directly, we certainly have a little bit of time for that and for more discussion.
Andrea, the only other thing I'd like to add is I've got the lucky role at the college of being a matchmaker between the experts we have at the college in various areas and community, needs of the community, and helping help resolve some of the problems we have in the community. On Plattsburgh, we have, I believe Akanksha mentioned the Center for Neurobehavioral Health. That houses our Alzheimer's Caregiver Initiative. We've got an autism program called Nexus. We have a program for traumatic brain injury, and a third age daycare for day program for people with Alzheimer's. And there's a lot of services that just wouldn't exist in the community if they weren't housed at the college. And but those partnerships are really important. I mentioned that telemedicine network way back in 2010. We never would have crossed the finish line if it wasn't for a partnership with the Fort Drum Regional Health Planning Organization. There's a gentleman there named Bob Hunt who's just worth his weight in gold And I can't imagine what the North Country would have been like during COVID, were it not for the groundwork that was laid back in 2010 by, with that partnership with Fort Drum. And then, so, we have some new faculty members that are looking at wellness, and Akanksha's got a lot of expertise in doing, various surveys and research on burnout and worker burnout and so on in healthcare and other areas. But we're here if you're ever looking for somebody to help with collecting data while you're preparing a grant, or it's working on an intervention or doing a program evaluation. Feel free to reach out. We may have some experts that can assist.
Thank you, Mike. And just a reminder to everyone, Dr. Anand and Mike's contact information is up on the slide right now. So you can feel free to reach out to either of them following today's session for collaboration or any other questions. We do have another question that came through the chat. Are you studying any specific strategies that might be employed in organizations to address burnout?
Yes, I think that's a great question. I'm excited. Yes, we are studying a lot of strategies. There are like two types of strategies in stress interventions. One is an individual level intervention, which I think most of us already know about, like the Headspace app or mindfulness or meditation. The other is organizational interventions. Organizational interventions are far more difficult to design and implement. That's where we're looking at strategically cost-effective interventions, meaning that how can we give rest and recovery breaks to, like Mount Sinai and Columbia Medical Center have rest and recovery break rooms for clinicians now after COVID-19. What that allows you to do is it's like a recharge and recovery room that we have like for NFL players, right? So what that allows you to do is it allows you to decompress, and the rest and recovery literature argues that you're able to reserve your cognitive resources better. So those organizational investment and resources like that, where you can have a quiet room to yourself for I think it's called the yoga or the wellness room. Don't quote me on that, but there is a room where you can go and sit and take a break and just do meditation or stretch or something that really helps. So we're looking for something that's cost effective, because organizations do not have the kind of resources to create a yoga room or something like that. So how can they have like time pod breaks at their place or at their desks for a little bit? So they could be away from the records or all of that for a little bit to just calm down and just like be, or maybe talk to a therapist if the need be. So there are some hotlines available for frontline workers after COVID-19. So yeah, we're working on very organizationally informed, so to say, interventions. And are we doing this research? We've done this research earlier with several nonprofits in the city, and now we are partnering up with some healthcare, behavioral health organization and other organizations, nonprofits, to collect data around the same survey to see, okay, which does supervisory support intervention works better or organizational support? If there are no policies to support supervisors, supervisors cannot support the frontline clinicians. So it's clear, the evidence around that is clear. So we're trying to come up with more effective, cost-effective organizational strategies to retain employees.
Thank you very much. Do we have any additional questions or any comments? We do have another question that came through. Is there an effort at recruiting foreign J1 visa clinicians to augment domestic providers?
Very good question. I am not an expert in immigration law, but given the fact that I'm an immigrant myself in this country, I will say this, that yes, there is an incentive if you're working in a healthcare professional shortage area, and you should discuss this with your lawyer. I'm not an expert on this. There is an incentive for a national interest waiver green card applications if you've served in HIPSA underserved areas like that of Clinton County or Franklin or Essex. These are underserved HIPSA areas for mental health services and primary care. So I do know of friends who've gotten national interest waiver residencies as a result of that. So yes, it is possible. Am I an expert to talk about it? No. So the answer is that yes, there is a pathway through the national interest waiver program. Yes.
Thank you. Any other questions? Wouter suggested reach out to Stefanik's office. They just helped with enhanced opportunity for J1 waivers. Wouter, is there anything else you wanted to add to that? You can feel free to unmute yourself and
Yeah, I don't know exactly. I just know that we've always faced a limitation on the number of J1 waivers that are available in New York. And maybe that's just for physicians, I don't know. But Stefanik worked with some organizations, so we now have a much larger, an unlimited pool of opportunity for J1 waivers. Again, I do not know what job classifications it's for. I don't think it's just limited to physicians, but their office would be able to help with that.
Thank you.
Thank you. Any additional questions or comments?
Thank you for helping us sail through our presentation.
This was fantastic. And again, please refer to Dr. Anand and Michael's contact information if you wish to speak with them following the session today. Thank you, Dr. Anand and Mike. This was a great presentation. Look forward to hearing more about the research that you're doing. And thank you to everyone for attending. As a reminder, we have 2 more sessions today at 11 o'clock and 1 o'clock. And we look forward to seeing you then. Thank you, everyone.
Thank you, everyone. Please feel free to reach out to us. We're happy to help and support.